33. So let's get started, if that's okay with you, Sarah. So I have the privilege to be hosting this seminar and introduce you, but I always feel it's very difficult to introduce someone as prominent and inspirational as you are. So I won't do a good job. I can't do a good job. But I can only say that your work has been inspirational to many scientists, including those in my lab and myself. And for those who may not know Sarah is professor of cognitive neuroscience at UCL, recently joining UCL, where she leads the clinical and affective group, neuroscience group, and she completed her PhD at the University of Sussex. And she then was a training fellowship in psychiatry and neuroscience at the University of Michigan before she moved back to Brighton and Sussex, a medical school, when she specialized in interoception. Many of Sarah's papers on interoception, the way your brain interacts with your heart, informs decisions and behaviors. She, through the reading of her papers, have understood that listening to your heart is not just figure of speech. And I'm so much looking forward to listening to Sarah's talk today, which is the clinical neuroscience and the heart, how cardiac signals influence emotion and cognition. Thank you, Sarah.
Oh, thank you so much for that lovely introduction. And it is so nice to see you all. My only sadness is that we cannot all be together, but hopefully soon. So I became interested in the role of the heart when I was doing my neuroscience psychiatry fellowship in Detroit, where I was based at the University of Michigan. And I was working with individuals with post-traumatic stress disorder. And I was trying to look at the neurocircuitry in the brain that underlie persistent fear responses. And the individuals that I would talk to would say the same thing, which is the world is an unsafe place. And they really felt fearful all the time. And I was interested in manipulating the role of the external context. So could I put people into safe rooms and dangerous rooms? And would this change how they felt about the world being unsafe? And it became apparent to me that they were not able to use the external context as a safety context. And there seems to be alterations in contextual processing. But what I was most fascinated by was if they couldn't use external context, and what was also the source of their fear? And was there something different about the internal context that was also driving fear responses? And I was observing that these individuals with PTSD had very different autonomic profiles. They had hyperarousal, increased activation of the sympathetic nervous system, racing hearts, sweat responses. And I wanted to understand how these autonomic signals could also shape persistent feelings of fear and maybe also fear memories as well. So I became interested in the role of the body and how it might shape emotions and the sense of interoception. So when we think about senses, we tend to think about hearing, smell, vision, taste, and touch, but these can actually be classified as exteroceptive senses. That is, they tell us something about the outside world. And in contrast, we have interoception, which is an inner sense. And interoception is formally defined as the process by which the nervous system senses, interprets, and integrates signals originating from within the body, providing a moment-by-moment mapping of the body's internal landscape across conscious and unconscious levels. And I focus particularly on the heart and how the heart can shape and influence cognition and emotion. And the real challenge lies in how to formally delineate and investigate interoception. And probably my main contribution has been to delineate different interoceptive levels for the systematic study of interoception and how internal bodily signals can shape the way we think and feel. And when I first joined this field 10 years ago, people were intermixing self-report measures, behavioural measures, with sort of little thought about what these different measures were tapping into mechanistically. And in this talk, I really want to delineate and discuss how these different interoceptive levels can influence the way in which bodily signals guide how we think and how we feel. So I'm going to talk about the afferent signal itself, and how this is different in different patient populations and what this might mean. So the role of the body in emotion has long been known. So William James in 1884 argued, as many of you know, I'm sure, that the bodily changes follow directly the perception of the exciting fact, and that our feelings of the same changes as they occur is the emotion. So he actually equated the sensing of internal bodily signals with the emotion itself. And this is a core construct of interoception. But what is often been neglected is the measurement of the afferent signal itself to see how it might also differ in different patient populations who may have different emotion profiles. So in this study, we studied close to 400 patients, and we looked at simple measures just of heart rate and heart rate variability. And we were able to demonstrate something that's actually been shown many times before, which is you have systematic differences in these heart rate and heart rate variability measures in different patient populations. So first of all, I'm going to focus on RMSSD, which is a measure of heart rate variability. The higher this measure is, the more variable the heart signal is. So schizophrenia, which is the least variable, has a very regular beating heart. And actually, this is a sign that the body is less adaptive and less reactive. So you actually want your heart signal to be varied. It's a sign of an adaptive and reactive system. And healthy controls, depicted in green here, have the highest level of heart rate variability, consistent with this idea that it is an adaptive signal. And you can see this sort of decline in this heart rate variability measure in all of these different mental health conditions. We also looked at just baseline heart rates, and we found some variability there, heart rate being lowest in our healthy control group and highest in our schizophrenia group. What's really interesting is maybe these signals are more meaningful than previously recognized. So I found this table that was in a JAMA psychiatry paper a few years ago now, but it was just in a table, it wasn't made too much of. But what it showed, and it was in this longitudinal cohort study, was they were able to show that individuals with a higher resting heart rate in healthy men who were joining the army prior to any mental health conditions, these individuals who had a higher resting heart rate had a 21% increased risk of schizophrenia. And again, this is before any schizophrenia symptoms were present. So is there something about a higher resting heart rate or something about the changes or alterations in the autonomic nervous system which are potentially predictive or core to the etiology of these different mental health conditions? And this is work that I'm doing right at the moment with one of my PhD students. And it's a very complicated paradigm using virtual reality and a number of other things. But I really just want to pick out one core finding, which is what happens to the heart when individuals either stroke themselves or someone else strokes them. And when someone else strokes them, that's the red line. Each dot is a heartbeat, and self-stroke is in this sort of, I guess it's sort of teal. And you can see that there's less of a reaction of the heart when people stroke themselves, and people have more of a deceleration response when they're stroked by someone else. And these are individuals who are less prone to dissociation. So dissociation is when you feel like maybe your body isn't in the world, or the world may be a bit unreal, or you feel a bit dissociated from your own memories or your own emotions. Dissociation is a transdiagnostic symptom. And we contrasted this to individuals who were moderate scorers of dissociation. And the cardiac response here decelerates for both self-stroking and other stroking. So here you're not getting a cardiac differentiation between self and other action for stroking. And this is interesting. It maybe ties into work by Chris Frith and others showing that individuals with schizophrenia or prone to schizophrenia are able to tickle themselves. So there's maybe not a tagging of self and other action in the same way. And dissociation is a transdiagnostic measure, but it also is very much comorbid with conditions such as schizophrenia and psychosis. So the take-home message I really want to make is that something that has been neglected are these fine-grained monitoring of autonomic responses and seeing how they differ in different conditions associated with different symptoms. So we can measure the afferent signal itself, but the afferent signal itself isn't actually technically interoception, because the interoception is more about the sensing of the signals. So we can measure the afferent signal itself and see how it's different in different clinical populations or different symptoms. But we can also look at the way in which the afferent signal is integrated with brain. And one of the ways we can do that is looking at the heartbeat evoked potential. So using EEG, we can look at the amplitude of a signal related to the heartbeat, where you've removed the cardiac artifact, but you're interested in this heartbeat evoked potential response. And really it's a measure, or can be seen as a measure, of heart-brain integration. And the amplitude of this heartbeat evoked potential can be meaningful. You see that it's changed in groups vulnerable to emotional disturbance, such as individuals with borderline personality disorder. And at the moment, in collaboration with a very talented neurologist called Mahinda Yogaraja, who's just joined my group on an MRC grant, we're looking at individuals with functional neurological disorder to look at heartbeat evoked potentials and how it might differ. And we're specifically interested in functional seizures. Now, functional seizures are different from epileptic seizures. In epileptic seizures, you see neural activity in the brain indicative of an epileptic seizure, whereas a functional seizure has behavior that looks like an epileptic seizure, but you don't get the brain activity of an epileptic seizure. So functional seizures have previously very much been seen at the intersection between psychiatry and neurology, and people have tried to find a sort of psychological driver for these functional seizures, which don't appear to have a neural origin the way that epileptic seizures do. But actually, we've now able to show that this heart-brain integration measure differs and is predictive of a functional seizure. So we measured in individuals with epilepsy and functional seizures, the heartbeat evoked potential. Interictal means in between seizures, and preictal means just before a seizure and predictive of a seizure. And we find that just in between a seizure, there's no difference in the magnitude of the heartbeat evoked potential response. But just before and predictive of a functional seizure, you got a drop in the heartbeat evoked potential measure, which is predictive of a functional seizure, and you don't get that for epilepsy. So these measures of heart-brain or body-brain integration can offer new insights into previously unexplained behavior based on neural activity itself. So again, I'm going to progress through these different levels to show how they map onto different behaviors, cognition and emotion constructs. So I've done the afferent signal expressed in brain, but we can also look at how the afferent signal changes the way that stimuli are processed. So every time the heart beats, it sends a signal to the brain. So the brain is flashing and in dynamic communication with our organs. Baroreceptors are mechanoreceptors located around the heart, activated, and they send messages up with ultimate afferent projections ending in a variety of areas, such as the insula, the LC, the amygdala, the MPFC. And I'm going to call T wave systole in brain, and that's when the heart-brain channel is in active communication and the brain is expressing for a moment the degree of cardiovascular arousal, whereas R wave is in between heartbeats when the heart-brain channel is quiet. And what you can do is present stimuli at very brief points in the cardiac cycle to see how this heart-brain channel, when it's active, changes the way that a stimulus is processed. And these experiments have been done for many decades now and historically focused in the sensory domain. And what they would do was, for example, present an electric shock very briefly and very fast at different points in the cardiac cycle. So on the horizontal axis here, you have R wave and distance from R wave. And you have on the y-axis the EMG muscle response to the electric shock. And you can see that a cardiac systole, when the heart-brain channel is active, the response to the electric shock is dampened down. So you actually have a dampening down of the reaction to the electric shock when the heart-brain channel is active. And this was consistent with the Lacey and Lacey idea that cardiac afferent signals had an interfering or inhibitory effect on stimulus processing. I initially, and I don't have the slide here, but just to briefly say, extended this into the domain of memory, where I presented words on and off the heartbeat, and I was able to show that individuals were more likely to forget a word if they saw it exactly when their heart was beating at cardiac systole. This is again consistent with the interfering effect of the heartbeat on memory, but was broadly consistent with the idea that heartbeats were always inhibitory or interfering. But because I really started off being fascinated about the heart because of fear and PTSD, I wanted to see, could there be something about the heart signal which could facilitate the processing of fear? And so I used a paradigm based on those that have been employed before, where I time lock stimuli to very precise points in the cardiac cycle, either at T wave or systole expressed in brain, or R wave in between heartbeats when the heart-brain channel is quiet. I presented fear faces or neutral faces, very brief time points, and then I got people to rate the intensity of these faces. And I was interested to see how these cardiac afferent signals could change fear processing, with the idea that cardiac afferent signals could potentially boost and augment the perception of fear. And that is what we found. We found that fear faces presented at cardiac systole were rated as more intense than fear faces presented at cardiac diastole, and that reverse was seen for neutral faces, where neutral faces were rated as less intense at cardiac systole, consistent with this more dampening down of processing with cardiac afferent signals. And we could also see changes in the brain as well, with a main effect of cardiac cycle resulting in insular activation, whereas amygdala activation actually tracked the cardiac modulation of fear, with increased amygdala for fear faces at systole relative to diastole, and the reverse being shown for neutral faces. And this is really very speculative initial study to see if we could take advantage of the differential processing of fear at cardiac systole to see if we could use it for therapeutic potential. So we were interested in exposure therapy, which essentially is a form of extinction. You present something repeatedly to someone, something they're scared of, like a spider, until people no longer have the same fear response to it. And we worked with spider phobics, and we wanted to repeatedly expose them to pictures of spiders to see if we could reduce their fear responses to the spiders. And we tested this with a behavioural avoidance task at the end, where we had a tarantula. It was dead, but it was large and it was hairy, and we stuffed it. It got taken to people at progressively closer intervals, and we wanted to see how close they could have it be brought to them as a measure indicative of how effective this exposure therapy was. And we had 3 groups in a between subjects design, where we showed people spiders at different points in the cardiac cycle, either at R wave in late diastole, which was one group, at T wave, systole in brain when the heart-brain channel was active, and we've shown that fear can be increased, and then also a random point where it was not time locked to the cardiac cycle. And what we showed was actually, it was this condition that was most effective in ultimately reducing fear responses to spiders, in the sense that individuals were able to have the spider come closest to them in this final test. And this struck me initially as seemingly counterintuitive, as this was a condition where fear was actually increased in our first experiments. But having worked a lot with people with post-traumatic stress disorder, where they were undergoing therapy to help them overcome their fear in terms of their trauma, we observed, and also there's evidence to suggest, that individuals who don't engage with this extinction-based exposure treatment are individuals who don't recover from their trauma in the same way. That if individuals are high in avoidance symptoms and aren't engaging with this, then they don't learn that it's now safe. So is there something about a mechanism that initially allows the fear to flood in, so people feel it intensely, that allows people to really engage with the fear as a way to really effectively extinguish the fear ultimately? It's just a hypothesis. But it does maybe lend the idea of extinction happening differently at different points in the cardiac cycle, and whether this can be exploited for therapeutic purposes. Another level that we can systematically study is interoceptive accuracy, which is the accuracy with which people can detect internal bodily sensations, and individual differences in the precision with which people can do this. I would say of all these different interoceptive levels, this is the one that's currently most contentious, where there is lots of debate in the literature about how best to study interoceptive accuracy. We have just edited a special issue on interoceptive methods, which is devoted to assessing new interoceptive methods. And anyone who is interested in different methods, this is now out and available. But historically, interoceptive accuracy has been investigated using the heart, because the heart is a discrete signal, which you can measure, and it's seemingly easy to quantify people's accuracy at detecting when their heart is beaten. And this has been done historically using 2 straightforward tasks. One, which is the Chandri heartbeat counting or heartbeat tracking task, where people silently count how many heartbeats they feel in a specified time frame. So a computer would say start, people close their eyes, they silently count how many heartbeats they feel, the computer says stop, they report how many heartbeats they've counted. At the same time, we're measuring how many heartbeats they've had, and we can compute a ratio of how many heartbeats they count relative to how many they actually had. And that ratio essentially serves as an accuracy measure. This has been criticized because higher order beliefs about heartbeats' capacity to track time might influence the number that people report. A measure which is not affected by beliefs in the same way is the Katkin-Whitehead test, where you play people tones in sync or out of sync with their heart. So tones and heart signals are either synchronous or asynchronous, and people have to judge whether they're synchronous or asynchronous, but the temporal information of the tones is the same, irrespective of whether they're synchronous or asynchronous. They're just time shifted off. This is more an internal, external integration task. It's a lot harder, but it's not influenced by higher order measures in the same way. Hugo Critchley did a seminal study where he was able to show that when you perform this heartbeat tone synchronization task in the scanner, you have activation of the right anterior insula, and the degree of activation in this area, in addition to the gray matter volume in this area, is correlated with how accurate people are at this task. And interoceptive accuracy fascinates me because it's a real individual difference measure. Some people are incredibly accurate at it, and some people really are not accurate at all. And now we have a measure in the brain, both in terms of its volume and in terms of its activation, which is correlated with this individual difference measure of accuracy. And then we also have self-report measures of interoception. How good do you think you are at detecting internal bodily sensations? And what I find so interesting about interoception is that subjective report really doesn't align with accuracy measures. So if I were to speculate for a while why this might be, and I hope you don't mind the speculation, is that exteroception, I think, has evolved to some extent to help you navigate the world. So you typically want to know if you've seen something, felt something, heard something, if you are attending to it. So it can be gated by attention. But if you're attending to it and if it's above a certain threshold, then to a large extent, it's coupled to conscious access. Whereas our brains are being constantly bombarded by internal bodily signals. Our brains are in dynamic communication with our organs all the time, and we don't want to be distracted by them unless it's essential, we're hungry, or it's something for survival. And then, yes, it's adaptive to have it coupled to conscious access. But most of the time, we don't want access to these signals in the same way. So the interoceptive system has, to some extent, deviated from conscious access. So you had this really interesting patterns where beliefs about how good people are about the body and what they think the body is doing doesn't necessarily align with what's actually happening. And you get higher discrepancies between self-report measures and behavioural accuracy measures of interoception in certain patient populations. So a lot of the work that I do at the moment is with autism, which is a neurodevelopmental condition where individuals display difficulties in understanding their own emotion and the emotions of other people. Anxiety is really, really highly comorbid in this group. 23 to 60% is said in the literature, but in the clinic that I was working with in Brighton and Hove, it was actually on the sort of upper end, if not higher than 60%. So anxiety was just so highly comorbid with these individuals. And then from a neuroscience perspective in the brain, you get different patterns of insular connectivity and reactivity. Machine learning analyses have indicated that altered insular connectivity is one of the things most diagnostic of an autistic brain. So there seems to be something special about the insula as well in these individuals. And of course, insula is the area which is particularly implicated in the sensing of internal bodily signals. And something I categorically disagree with is that historically people have said that empathy is impaired in autistic individuals. And I think this is just not true. And actually, there may be impairments in understanding what's going on, but that doesn't equate to a empathy deficit. And actually, if you look at the role of the body and what it's doing, it tells a very different story. So in this experiment by Gu et al., in which they were actually claiming empathy deficits based on self-reported neural activation. If you look at the role of the body, it tells a reverse story. And they were looking at skin conductance to watching other people in pain. And actually, the autistic group had a higher skin conductance response when someone else is in pain relative to healthy controls. And this wasn't true for non-pain stimuli. It was specific to pain stimuli. So it wasn't just indicative of overly reactive body. It was a high empathy for pain bodily response in the autistic individuals relative to the controls. So actually, is there something altered about interoception rather than the bodily empathy response itself? And if this was a talk about autism, then there are many examples that I could give to detail how autism might be related to interoceptive alterations. So altered eating patterns in autistic individuals are very well documented. There's high incidence of anorexia in autistic women. So individuals don't necessarily know when they're hungry, or they find it easier to suppress hunger cues. Or the reverse can be true, which is they like a food so much, they carry on eating it and eating it. And maybe that's because they're not getting the same fullness sensations. So intuitive eating is a phenomenon where you eat when you're hungry and you stop when you're full. And it's thought to be interoceptive, and this seems to be altered in autistic individuals. I've done some work looking at intuitive decision-making guided by signals in the body, and this seems to also be altered in autistic individuals. Emotion processing is very much linked to the sensing of bodily sensations, and alexithymia is very high in these individuals. So there are many examples of how the interoceptive system might have gone awry in autistic individuals. But my work was the first work to look at interoceptive accuracy in autistic adults. And we hypothesized that these individuals would have a deficit or an impairment in interoceptive processing, focusing on the heart. However, what we often observed in the clinic is that autistic individuals would often say that they were very aware of what their body was doing. So we also hypothesized that they would have an inflated belief in their capacity to be interoceptively accurate and aware. So this speaks to this interesting potential dissociation between accuracy and precision of bodily signals and beliefs about how good you are at interoception. And what we found, and this was using just a simple heartbeat counting task, which is very accessible to this population, we found that at the group level, individuals who were autistic, the red dots, at the group level, they were impaired in interoceptive accuracy. You can see here that it wasn't every individual, but it was marked and demonstrable in certain individuals and significant at the group level. And this contrasted with this questionnaire measure of how aware do you think you are of bodily sensations. And here the autistic individuals said, I'm very aware. So you get this fascinating double dissociation between precision and self-reported awareness. Extending this deficit in interoceptive accuracy was work done by Palsa et al., who repeated this interoceptive accuracy task, focusing on the heartbeat counting in children and adolescents aged 6 to 18, suggesting that it's potentially something that manifests early. I'd also really like to highlight the work of Jeff Bird here, who matched autistic and control individuals for levels of alexithymia. Alexithymia is defined by impairments in emotion processing, such as difficulty detecting feelings, difficulty identifying feelings. And they were able to show that actually it was the alexithymia which was driving the impairments in interoceptive accuracy rather than autism per se. I think an autistic individual that has no alexithymia is maybe slightly atypical in terms of their presentation. But what I do think this tells us is there's something entwined about the sensing and understanding of bodily sensations with this interoceptive accuracy measure, which actually beautifully aligns with the works of William James in terms of the role of the body in helping guide the sensing of emotional feeling states. But I was really interested in this discrepancy between self-report measures and accuracy measures. So I was interested in what happens if people had this inflated self-report measure, but low precision. So I Z-scored both measures and subtracted them as a means to derive an error score, which I called the interoceptive trait prediction error. High levels are when people have very high self-report measures, but low accuracy measures. And I showed that this correlated with anxiety. So if people had strong beliefs about their ability to be aware of the body, but low precision, then they potentially have unaccounted for arousal, and they're not able to have this precise access to bodily signals despite their belief that they do. And this seems to be related to high anxiety symptomatology. And this led me to hypothesize, could we increase interoceptive accuracy? And if so, would this reduce anxiety? So in a proof of principle, just pilot study initially, we worked with 30 individuals who are not autistic and matched control individuals who are also not autistic. And our control individuals just had interoceptive accuracy assessed at 3 time points using the methods that I've talked about, the counting the heartbeats, the judging when the tones are in sync or out of sync. In addition, the group in the interoceptive training group condition, they were trained to be more interoceptively accurate. And we did this very simply. Interoception, as well as being a trait phenomenon in the sense that some people are good at it, some people are poor at it, is also a state-based phenomenon. So if you've run for the bus or if you're very scared, you can feel your heartbeat pounding more obviously. So we got people to do star jumps and light exercise as a means to elevate their heartbeats. They were then getting stronger interoceptive feedback. We then repeated these simple heartbeat counting tone synchrony judgments with them, and then told them whether they were correct or incorrect. So now they're having interoceptive feedback from the beating heart, stronger and faster. Exteroceptive feedback, we're telling them whether they're right or wrong. And this happens while their heart signal returns back to baseline. So they get a fading signal and they're able to stay within this interoceptive channel. The idea is as their heart signal returns to baseline. And then we tested their interoceptive accuracy at this baseline, midpoint, and final session, but with no cardiac exercise manipulation and no feedback, just to see whether they really have improved. And again, we looked just at counting heartbeats over successive timeframes or judging whether tones were in sync or out of sync to see whether they improved. So initially, in terms of our heartbeat counting tracking paradigm, just can they count how many heartbeats they have in a specified time frame, we were able to show big improvements. This I do not find convincing at all, because just the knowledge of your heart rate could potentially lead you to do this accurately. What I do find compelling, though, are these synchronicity, in sync, out of sync judgments. We ran signal detection analyses on them to look at a sensitivity measure. This is also an internal external task. The tones are always at the same rate, irrespective of whether in sync or out of sync. The out of sync is just a 300 millisecond shift. It's a very difficult task to do. People are at chance initially, hovering around 0. And we were at the group level able to show increases in this very challenging method in our group that underwent interoceptive training. And then what's really exciting is we weren't just interested in interoceptive accuracy and whether we could train it. We wanted to see whether there was any drops in anxiety. And we were able to show that in our training group, there was a group level drop in trait anxiety as assessed with the STI, and that both state and trait decreases in anxiety were coupled to increases in interoceptive accuracy. So the more accurate people got, the more their state anxiety dropped, but also trait as well. So there seems to be a relationship then based on that, maybe between interoceptive accuracy enhancing and anxiety decreasing. In addition, we also gave people a questionnaire, which was the Maya questionnaire for people interested, that looks at subjective measures of interoceptive experience. And it measures these other dimensions as well. One pertaining to not worrying about interoceptive signals, and also looking at attention and capacity to have flexible attention between the self and the world. And we also found 2 measures of the Maya, the not worrying and the attention regulation, also predictive of a drop of anxiety. That is, it seems to be 3 things which are crucial: precision and accuracy into the signal itself, not worrying about the signal. I think this, for me, very much aligned with Clark's models of anxiety. You don't want to worry that you're having a heart attack if you notice the racing heart, or have a negative attribution of what the heart is doing. You want to have precision into the signal, notice the signal, but not worry about the signal. And also you want to have flexible attention. You want to attend to your body when necessary, but attend to the world afterwards. And this reflects the fact that individuals who are prone to anxiety often have a bias to be overly focused on the body, and that's not healthy either. So you want precision into the signal, not worrying about the signal, and not be overly attentive to the signal, only when necessary. So we took these principles into a registered clinical trial in autistic adults. We worked with 120 autistic individuals. They were on sort of, I mean, what's great about this task is it is accessible. There were, I think, 3 individuals in this trial that were also nonverbal, and we worked with them to help them do this as well. And we took brain scans before and after interoceptive training to look at changes in neural connectivity. And we looked at measures of emotion and anxiety, followed this interoceptive training. We wanted an active control condition, and we chose this prosody exteroceptive control. Autistic adults often say they feel very anxious in social situations, not knowing what emotion the other person is feeling. So we wanted to teach them to better identify what emotion is being expressed using emotional prosody. So is the sentence said in a happy way or a sad way? And we trained them. And we thought this would serve as an exteroceptive training condition to reduce anxiety that would complement our interoceptive training condition. And we also looked at changes in emotion and anxiety. In terms of our outcome measures, in terms of interoceptive accuracy, so AD is our interoceptive training group. It stands for Aligning Dimensions for Interoceptive Experience. Control is our prosody group. Interoceptive training is in red, and we can see that for interoceptive accuracy using the internal-external task, this is our D prime sensitivity measure, we were able to train autistic adults to be more interoceptively accurate. Moreover, and this I find this really interesting, and I put this in, even though it's probably one of the harder ones to explain, but this is our self-report measure. And actually what we found was that our autistic group reported being less aware of interoceptive and bodily sensations following the interoceptive training. So there's something about having better accuracy that then made these individuals report being less aware. We don't know why. Mechanistically, this isn't known. Is there something about interoceptive surprise, which is more likely if people have less precision into the body? But I find this really interesting. And then in terms of our outcome variable, we, at the group level, showed a significant drop in anxiety in our interoceptive training group. We've published this to show it lasted at 1 week and 3 months post-intervention. And then unpublished, but just unblinded, is our 1 year, which again, I'm really happy about, which is the effect maintained after 1 year as well. And although this was significant at the group level, it seemed to be that it really worked in some people and not others. So we had a criterion that we pre-registered ahead of time, which is our criterion for recovery. Of course, it's just what we called recovery. It's arguably not recovery, but we defined it as a 6-point drop in trait anxiety, which on a 20-point scale is arguably meaningful, and that it had to be below 55. And according to this criterion, just over 30% recovered in our AD group, and half of that in our control group. So it seems like this therapy is more effective for some people relative to others. And then we also looked at scans pre-post the interoceptive training to look at functional connectivity. We put seeds in the insula, and what we were able to show was that there was increased right insular connectivity with this area in the ventromedial prefrontal cortex. And this increase in insular BMPFC connectivity correlated with the enhancements in interoceptive accuracy. Likewise, we found increases in left insular connectivity with this ACC region, and this also was coupled to increases in interoceptive accuracy or correlated with. So I interpret this, maybe it's too simplistic, I'd be fascinated in other people's thoughts, with VMPFC as being a regulation area. So this is maybe indicative of the relationship between accuracy and control, where greater precision into the signal helps you control the signal. And this is this right insular VMP connectivity. Whereas in terms of left insular connectivity and this ACC region is also an area where you see arousal in the brain if you model arousal state. So I see this as an alignment of arousal represented in the brain, making it more coherent with interoceptive training. So interoceptive training both aligns and brings coherence to arousal signals in brain, and also potentially aids their regulation. The reactions to the AD study from the autistic individuals themselves, I just wanted to talk to you about some of these because I also find these so interesting. So one individual said, as the inner channel gets clearer, the outer channel gets more quiet. Autistic individuals often have hypersensitivity to extraceptive senses. So they can often feel overwhelmed by noises in the environment or lights in the environment. It can be too much. And this suggests that enhancing the clarity of the interoceptive channel helps quiet the sort of extraceptive world. And it really makes me see interoceptive and extraceptive processing like a seesaw. And if you don't have good clarity to internal senses, and external senses can dominate. And if you can help redress the balance between the two, then it can maybe make the outside world less overwhelming. And interoceptive training can help provide that resetting of the seesaw. Another individual said, when I notice the impacts of anxiety on my body, I'm more aware of them and able to reassure myself that it's just a physical reaction. I'm better at taking deep breaths and trying to slow my breathing and heart rate down rather than letting it spiral. And this for me speaks to the not worrying about it. So reassuring myself it's just a physical reaction, not worrying, and also early access to the signal aids regulation. So if you just start noticing your heartbeat ramping up, then you're able to take deep breaths, calm yourself down. Whereas if you notice when you're already in the middle of a panic attack, it's harder then to have access. It's harder to regulate that signal, which is already too high. And then finally, someone said, I believe it's increased my awareness of hunger. And as a result, I remember to eat, drink, and go to the toilet. And this speaks to a debate that we're having at the moment in the interoceptive literature, which is to what extent are different bodily axes aligned. And this suggests that training in one dimension could potentially enhance access to the other bodily axes as well. So implications for new treatments. I think this is an exciting time where I do wonder how interoceptive mechanisms may help inform novel treatments for different mental health conditions. And I, of course, got into this area initially from working with individuals with PTSD, looking at heightened afferent signals and wondering how this changes in the internal context could drive fear and other types of processing. I find it so interesting that there is a clinical trial happening. It's just about to finish actually in the States and in these institutions, which really are the sort of world leading institutions. And they're giving losartan, which is a blood pressure medications to individuals with PTSD. And blood pressure medication very much acts on the cardiovascular system, where I was able to show that cardiovascular activity heighten fear processing. And so to what extent is a drug acting on the periphery like this able to then shape subsequent fear processing? And it seems like my experimental work potentially complements this intervention, which is being tried out right now. From a different perspective, there is work that's done, again, looking at medical records. And this wasn't hypothesis driven. This was just looking at big data to try and find associations. And they were able to show in the medical records of over 100,000 individuals in Sweden that severe mental illnesses such as schizophrenia, bipolar, and others displayed a 10 to 20% reduction in episodes when individuals were taking medications that again targeted things like blood pressure, such as statins. So there seems to be something protective about these blood pressure medications for severe mental health conditions, and very little is known about this. But in conditions like schizophrenia, where drugs really haven't progressed for a long time, to what extent could targeting these peripheral systems be informative and efficacious? So to conclude, interoception can be delineated across different levels and different bodily axes. I focused on the heart, but there are other ones as well, all of which have the potential to be informative in different ways. Some of these levels correspond, others are dissociative. And we find associations and interoceptive alterations may be particularly prevalent in some clinical conditions. I focused a lot on autism. And a comprehensive normative understanding of interoception will allow us to investigate the nature of these selective alterations in different clinical conditions. And it's my hope that this will also open up the potential for new treatments in the future. So that's everything. Thank you for listening. Thank you to the funders who I'm so grateful for, and for my collaborators and members of the lab who I couldn't have done it without them.
Thank you very much, Sarah, for this didactic and very exciting talk. That was great. Thank you very much. So some of the attendees have already posted questions in the chat. But perhaps if you're still here, Danielle, perhaps you could either say your question or read it, or I'm more than happy to do it on your behalf.
Yeah, very happy to. Hi, Sarah, how's it going?
Hi, Daniel, nice to see you.
Yeah, you too. So my question was, in terms of heart rate variability and baseline heart rate, is physical health a confound here? So in other words, maybe schizophrenics are the best or the least physically healthy, and this causes a higher propensity for mental illness.
So that's why I really think the pre-morbid studies are vital to be informative, because these were healthy. The initial, although yes, my personal studies were done in individuals with schizophrenia, where you're right, they've got higher BMI, there's many more physical health problems. So you're absolutely right in terms of the cross-sectional data, but it's why I wanted to have that little arrow and highlight the longitudinal data, which I see as complementary, because in that complementary data, they're working with 18-year-old men who are going to join the army in a large-scale population-based study. There's no premorbid conditions. They're healthy men, and they find a heart rate higher than 80 is predictive of schizophrenia. I think raises the likelihood by 21%. What is that driver? At that point, they're pretty healthy, and physical differences are minor between them.
Okay, thanks.
Danielle, I know you have another question, but Faith had one that was very related to this one. So Faith, if you want to speak to your question.
Sure, yeah, thank you for the talk. That was great. I was just wondering if you had any ideas or hypotheses about the mechanism underlying those lower HRV recordings in so many different pathologies.
So there's certainly work done by people linking heart rate variability to measure of flexibility, and it's body flexibility that can also map onto cognitive flexibility as well. You see a nice relationship between heart rate variability and ventral medial prefrontal cortex activation. So people have suggested that it's indicative of a non-reactive body that's not able to respond to necessary stressors in the right way. In terms of mechanisms, I think it raises a possibility of autonomic drivers, I think, as being strongly implicated in these different mental health conditions. There is work done, but very little, looking at scans of the heart in individuals with schizophrenia showing altered cardiac morphology. However, these are in patients who, like Daniel pointed out, have different health disparities, also are on medication that can also affect the heart. And so separating what is a consequence of schizophrenia versus cardiac morphology differences, which are vulnerability factors, still needs to be seen. But I would wonder about future work trying to probe more these cardiovascular mechanisms to see what could be driving the differences. And I don't have a very good answer yet.
Thank you, Sarah. Before we go back to the questions in the chat, Karen and Sarah Jane have questions now.
Thank you, Sarah, for this really interesting talk. I would like to follow up on Faith. I assume at the beginning you showed heart rate variability measures. You measured them at rest when people were lying down. Is that correct?
We did various things. So we've done experiments where we do measure them at rest. In this one, we were actually measuring them while they just did a very light task. I think they were looking at, they may have been silently counting their heartbeats. They were doing a very sort of light interoceptive task. But so it's possible that that could have an effect, but we've also done studies which is at rest, and that seems to follow the same pattern. And it replicates lots of work in the literature, which also is typically done at rest.
Yeah, because Faith is my student, and we've done work in people with cocaine addiction, and we measured heart rate variability twice. Once when people were lying down, supine, and we asked them then to stand up. And that is the level of adjustment of the sympathetic system, and people with cocaine addiction fail. They can't adjust. And that is quite interesting because in real life, they also show maladaptive behavior. They don't adjust. And I was wondering whether you see parallels with other aspects of adjustment.
I really like that, because that's very much also linked to the sort of flexibility idea as well.
Yes.
Yeah, which really aligns with that. So I love that example. Thank you. We have not done, my colleague Jessica Eccles has done more work on tilt tables and other things looking at posture changes. I haven't personally done it, but I find those kind of questions really interesting. I'm starting to get very interested in chronic pain, and to what extent are you seeing less reactivity or altered changes in adjustment and flexibility in the system there. But it's not an area I've looked at, but I think it's reactivity and flexibility of the system could be key. So I thank you for the question. It's something I'm thinking a lot about.
Sarah Jane.
Oh, hi, Sarah. Thank you. That was really interesting. I had a question. Actually, I've got lots, but I'm going to just choose one, and that's about the interoception for your own versus other people's heart rate. I think it was, right? You presented it right at the beginning.
Oh, yeah. So that was the dissociation. So that was looking at people stroking themselves.
Oh, that's right.
Yeah, because this is your work. This is a tickled. Yeah. No. Great. Yeah.
Yes, I was really interested in that, and particularly the mechanism there, partly because I thought, I mean, the stroking, you have the motor command, so then you could use the motor command to cancel the sensation. But when we were doing that work, Chris Frith and others and I used to talk about how bodily sensations were an interesting sort of exception to the rule, because you don't control with a motor command your heartbeat or your intestinal muscular changes, and so you do feel those in the same. Well, the argument would be you should feel those in the same way that you feel an external sensation. But I wondered that your experiment was interesting because it's a kind of combination of the motor command and the internal bodily sensations, and I wondered whether you've thought about the mechanism there.
Oh no, this is where I want you to tell me the mechanism. I feel like you're right, it has the confound. Actually, I'm going to bring up the slide again. It has the confound of the motor command, just like you say, and I genuinely don't know what the driver is. So this is, you can... I
mean, it's not really... wouldn't say it's a confound. It's more like that's the key.
Okay.
The driver. That's the basis of the forward model of prediction. But I guess what you could do is, well, we did some experiments. I mean, this is literally decades ago, but we did some experiments where we manipulated the relationship between your movement and the sensation. So with Daniel Woolpert's robots. So you moved your hand, and then we manipulated the delay between your own movement and the sensation you received on your other hand, and looked at how that related to the cancellation of the sensation, which it did. And we also did a kind of spatial perturbation as well. I guess you could do that, because in that case you would have the same motor command. So it would no longer be a confound, but you'd be able to look at how precise it is with relation to the cancellation.
Well, it's so interesting you say that, because I don't know if you remember my lead in, and I don't want to take it over because about this, but I said it was a really complicated experiment involving virtual reality. So what it actually was doing was it was making a systematic delay between the visual input and the touch sensation. So you can, using augmented reality, put a delay on the visual system so people feel the touch before they see the touch. We systematically varied that, and actually our biggest effect was this self-other stroking heart thing, and we couldn't get too much out with a delay, or it was overshadowed by this other effect.
Oh, interesting.
Yeah. So and we're writing
yeah, very interesting.
It is, and I would love, I'd love to speak to you more about it, because I am puzzled by it. Yeah. Thank you.
Thanks, Jane. Angela, you had two questions in the chat, which I believe relate to one another. So why don't you have a go at it? You're muted.
Thank you. Well, my first one was, it was just about the sort of intriguing finding about heightened sensitivity to stimuli depending on quite when they hit the heartbeat, and whether you get it in the systole or diastole components. But I was kind of thinking, how does that really map onto every day? Because you don't see stimuli impinging on your tiny bit of your heart rate at some specific point most of the time. So I was trying to work out in sort of in normal situations, what could be the use or rationale for that? Or is it just some kind of epiphenomenon that you found, which could end up being really useful for treatment, but is a sort of epiphenomenon? Or does it really tell us something more about the whole system?
So if I were to speculate, I think it's tapping into a mechanism which is informative for the whole system. So when your heartbeat signals to the brain a degree of cardiovascular arousal, you have for that moment activated a degree of cardiovascular arousal in the brain. That can happen on a moment-to-moment basis, but it can also happen chronically if you're very scared or you're in a high arousal state. So you have this interesting on and off the heartbeat mechanism, which is the same mechanism that happens when you're in a more prolonged state of fear. So you get a prioritizing of certain types of processing when you're in that state. So pain was dampened down, as I showed initially, and fear seems to be heightened. If you are running through a wood being followed by a bear over cut glass, you are less sensitive to pain in that high arousal state, and you're more hyper reactive to fear in the environment. So it seems like you get these chronic changes in the body indicative of high arousal states that selectively prioritize and dampen down different types of processing that map onto this moment-to-moment mechanism, which is
right. I'm with you.
Okay. Yeah, does that make that's how I explain it?
Yeah, I think I see what you're saying. And just so related to that then, but I'm not sure it is how related actually, David, but it could be. I would like to ask it anyway. Is the interesting thing that you showed about people, if they became more interoceptively accurate, they actually became less aware of being accurate. They actually become less aware of what's going on in a way, even though they're actually more accurate. And you obviously mentioned this thing about possibly mismatch, but of course there's a big hypothesis about mismatch, interoception and anxiety. So I was just wondering whether you thought you could, with what you've started to do, whether you could actually test that more easily with the kinds of paradigms you're using for getting at this whole concept about, is it because that's exactly what the problem is. It's a mismatch. When people don't understand what they're, and certainly aren't predicting what their interoceptive feelings are, then the mismatch is what's causing the problem.
And certainly that's what my data seems to suggest. Yeah. Because the accuracy seems to do the training which reduces the anxiety does two things. It reduces the mismatch both by heightening the interoceptive accuracy, which is not a surprise. We were training them on interoceptive accuracy. The surprise was something we weren't training them on at all, then decreasing. So I think it does speak to that. Whether we can do it in a more targeted way is interesting.
Look at neural signals related to that.
Yeah, we have, you're right. We haven't modeled, we modeled in the increase in interoceptive accuracy, which is the data I showed, but you're right, we have not modeled the mismatch.
That would be really interesting to see where you're getting it, as to whether, in terms of previous literature, and whether it's somewhere in the insula where you're getting that mismatch between the awareness and the accuracy.
Yeah. Yeah, and what that might be coupled to as well in terms of connectivity. Yeah, it's a great idea.
I would like to come back to this question if possible, but Brian has had his hand raised for some time. Brian.
Yeah, I'd like to go off slightly at a tangent, but many military personnel who have PTSD also have hyperacusis. They're very sensitive to sort of moderately high level sounds that don't bother most people, as are autistic kids. And there are two issues here. One is sometimes these soldiers are claiming compensation for the disorders that they have, including hyperacusis, and there's no accepted objective way of diagnosing it. But do you think their reaction in terms of changes in heart rate could be a diagnostic test for hyperacusis. So that's one question. And then secondly, do you think the training methods that you've talked about could help with hyperacusis as well as generally the symptoms of anxiety and so on?
I've never thought about it before, but I really love the question. And I think, yes, it could be a training mechanism. I think it's your point about PTSD is so interesting. And I knew it, but I sort of hadn't put it together in the model. So thank you so much. And I think your population would be perfect for looking at the seesawing between the senses of the interoceptive world and the exteroceptive world, and it would be a very elegant population to test that model on to see. I really love the suggestion. Thank you.
Thank you, Brian. So if I may come back to the previous point that Angela raised, this notion of mismatch could be perhaps related to your insular ACC, insular VMPFC circuits towards the end. Because if I'm not mistaken, there are suggestions that access to consciousness of interoceptive states requires interactions between the anterior insula and the ACC, whereas work from Bashar and others and some of work from the previous lab has shown that VMPFC may be very important for recruiting some somatic priors. And the SCR, for instance, in the hierogamic task may well be dependent on the integrity of the VMPFC. So the question could be, is there a balance between the two systems whereby one informs the other, and then the other triggers priors that rely on heart rate variability, which is necessary to anchor learning about interoceptive states and make predictions about the environment? So in that case, you would predict that one system should show increased functional connectivity and the other one would compensate by a decrease. And perhaps the best strategy would be to balance these two with perhaps neurofeedback. So Angela was referring to neural signature of these mechanisms, but perhaps that very neural signature could be used for neurofeedback.
It's a great idea. It's great. And I really like the way that you went through the circuitry. Yeah. It would be a great way of testing the model.
Thanks. Danielle, should we come back to your second question?
Yeah, that would be great. It's more just sort of curiosity. So in terms of the discrepancy between interoceptive awareness and interoceptive accuracy, I was wondering if there is any correlation or indeed anti-correlation between IQ and either of those things, IQ and interoceptive awareness or IQ and interoceptive accuracy.
IQ with accuracy, yes. It depends what test you're doing. But people like Jeff Bird have said it is a confound. We try to match our groups on parameters indicative of that when we're doing work. I don't know about interoceptive awareness or sort of metacognition measures, but one would absolutely predict that they would probably be related to it as well. Maybe such that they would cancel each other out, or the metacognition measure may be more related. As a metacognition expert, I'm sure you know. But yeah, I would predict, if anything, that would be more related. And potentially cancelling each other out. But the reason I quite like, even though they're controversial, people don't necessarily like, they like the more complicated psychophysics-based interoception paradigms. There is something to be said for the simpler ones when working with patients, because they're very accessible, they're very easy to understand. And IQ is less of a confound, they're fast to do. Attention doesn't dawdle, people comprehend them. So they are well matched for patient work for those reasons. They're more accessible.
Thank you.
Thanks, Sarah. If I may, coming back to this notion of heart rate, and so there is frequency and variability. And in the first slides of your presentation, you've shown how the two would change. So you've got increased frequency that often comes with decreased variability. So my question is it a physiological adaptation? The higher the frequency, the less room there is for variability. So one drives the other. And do you have any particular conditions in which the two are dissociable and dissociated? And the second thing is, have you ever thought about doing ASM alongside MRI or your tasks, because increased blood pressure results in physical constraints on the brain. The brain moves upon each heart contraction, and I was wondering whether there could be neurophysiological entrainment of neuronal networks simply due to the physical constraints on the brain that follow heart rate contractions that may have nothing to do with our ability to sense the heart per se, because it would be the brain that moves in response to it.
So you're absolutely right about the physiological constraints, and I'm interested in things like the heartbeat evoked potential, which modulates less of attention as a function of high blood pressure. So you get these interesting patterns that happen with these different bodily states. I don't know too much about that area at all. What was your first question? I'm so sorry.
Well, the extent to which variations
and then variation,
are driven by the narrowing of physiological room by increased frequency.
There's definitely some truth to that. You do see constraints in the degree of variability attainable with high heart rate. So there is under typical conditions. So there is some truth to the fact that they are inversely related. However, there are really interesting patterns that you can get. For example, you do get high heart rate variability under certain conditions, such as the sort of novelty elation feelings. And I think that's this kind of state that no one had in lockdown, where you're all being very repetitious, nothing surprising you, like those kind of. So there are states that you can get in where the two go up together, but they're rare and they're associated with these incredibly positive feelings, but they are possible. But you're right, typically you see it as a physiological constraint, which limits the degree of variability, and an inverse relationship manifests.
Thanks, Sarah. Deborah has been waiting to ask a question, but since you've once again referred to the heartbeat evoked potential, and Jordi is very much interested in this, Jordi, would you mind to ask a question to Sarah?
Yeah, thank you. So I'm actually a neurofeedback practitioner and do a lot of biofeedback and neurofeedback with clients. And I actually haven't heard of the heartbeat evoked potential specifically. Obviously, evoked potentials, but not the heartbeat part. So I was just wondering if you could speak more to that.
Yeah, so it's, I feel like Tristan's done work on that. So it's where you look at the amplitude of an ERP a certain amount of time after the heartbeat. So it's associated with the neural processing of heartbeats, and it's done in such a way where you're able to remove the cardiac artifact itself. What's really interesting about the heartbeat evoked potential is it's both state dependent. So when you get people to focus on their heart, it gets larger, and you get them to focus on the world, it gets smaller. So it's a measure of self-focused attention. In addition to these state-based manipulations, you can also see trait-based differences. So individuals with borderline personality disorder who often have emotion dysregulation, problems of self-other monitoring and boundaries, they have a trait-based change in heartbeat potential where it's down. And then you also get, as I showed you with the functional seizure people, it's a measure potentially of body-brain integration, and it's indicative and predictive of these also functional dissociative seizures. So it seems to be this really interesting measure of body-brain integration that's predictive of these different state and trait-based phenomena.
Great. And the only other thing I'll add to that, as just personally, I've been practicing yoga for a long time, and just that awareness, the proprioceptive awareness and interoceptive awareness on the body. It seems that there's also, and I could see this in autism as well, but there's an overwhelm piece of having so much awareness, and then like a dissociation or a disconnection to that awareness. So like kind of some of the things you were saying, that with more awareness, that there's kind of a less, I think it was more, what was it, more awareness?
Accuracy.
Yeah, less accuracy. And that's what came up for me, is kind of like, oh, more awareness. And your attention can only go so far. There's only so much you can integrate at one time and be aware of at one time. And I would think that you know, okay, I'm super aware of this, and now, oh, now I'm learning something new, and it's only 3 months later, that integration process, that dissociation or a cognitive dissonance, really, I could see that being hard for them.
Okay. Yeah, that's so interesting. And yeah, and I think a lot about being overwhelmed as well. Like autistic individuals often say they're overwhelmed by their body,
Yeah.
and maybe see overwhelming feelings that relate to a reduction in precision and accuracy and a greater infiltration into consciousness. And it sort of, yeah, maps onto this self-report measure.
Yeah, that's what I was thinking when I saw it. So I just wanted to put
Yeah, cool. No, I really appreciate, especially as you work with the individuals themselves. So the fact that your experiences with them mirror these findings is very exciting to me. So thank you.
Yeah, thank you. It's as a clinical worker, it's just wonderful the work you're doing. So thank you so much.
It means a lot. Thank you.
Thanks, Jordan. Deborah.
Thanks. Such a fascinating talk and touches on so many areas. It's so applicable to so much of the research that so many of us are doing. So thank you so much. I was just blown away by it, and I'm going to have to think and digest for a long time. But I have a specific question about the ASD study that was just fascinating. And it goes back to the questions on mechanism, that you had a few of those. Could you say a little bit more about what you think was the active ingredient in that study? Because, you know, how did the main group compare to the control group, for example? And what do you think in the intervention may have particularly mattered? So there's so many things, like they were doing exercise with somebody, they were told external feedback, they were told to listen to their own body. Like, what do you think was the difference, and which one of these were controlled in the control group and which weren't?
So I think it's a good question. And I think the way that I presented it made it sound like there's lots going on, whereas really, and it needs to be proven, but my instincts is that all the exercise and things they're just a means to an end, which is to help people understand and have good perception into what their body's doing. Like the exercise is just a means to an end. It was allowing the signals to be more noticeable, then people are able to lock into them better, and they get better precision into understanding what their body's doing. So I think bodily precision and interoceptive accuracy is, for me, the critical element. There may be another element as well. When they're doing exercise and they're feeling their heart rate, there may be some sort of mild exposure. They're getting used to their hearts doing different things and learning that's okay. So there may be something also about feeling their bodies and experiencing their bodies in different states and knowing nothing bad's going to happen. But for me, it's about precision into bodily signals, and everything is just a sort of mild way to get you there.
Right. So could you say just a tiny bit more about how the precision was achieved? So were they told immediately, oh, yeah, you're right or you're wrong?
Yeah, I'll give you a little example of a trial. So they would have a pulse oximeter on their finger. They would do some exercise, so jump up and down. They can feel their heart beating. We put a pulse oximeter on their finger. We then play them tones in sync or out of sync with their heart. And then they have to say whether the tones were in sync or out of sync. And we'd say correct, wrong, and then wrong, correct. And we just carry on doing trials. Their heartbeat would fade back down to baseline. We'd carry on doing the trials of them. You're correct, you're not correct. So they get a reduction of interoceptive feedback as their heart goes back down to baseline. And that's all it is.
Wow, fascinating. Thank you very much.
Sarah, if I can come back to this notion of gap between accuracy and awareness. I guess this is not right now on the radar for you, but it would be fascinating to determine whether a marshmallow-like test at early ages, before the insula has matured to adaptively labeled interoceptive inputs as that emotion and that emotion, whether that predicts subsequent discrepancies between accuracy and awareness. And the other question I had was the extent to which individuals develop strategies with regards to dumping their awareness as a coping mechanism. So we were referring to autistic patients who necessarily experience overload, may it be exteroceptive overload or interoceptive overload. And what you've shown is that if you make the ability to ascribe salience to a particular interoceptive cue by increasing accuracy, they become less aware. Is it a consequence, or is it them, even though non-consciously, adapting to this increased awareness to decrease the overload? And in that case, have you considered experimental designs in which, instead of manipulating one of the interoceptive or exteroceptive system, you make the two systems work in competition and determine whether they can differentially rely on one or the other, or completely shut off and stop relying on both?
I have not thought about it, but I like it. I mean, it's a good idea. They're interesting questions. What do you think?
Well, I'm biased. First of all, I know nothing about autism, so it's very easy for me to come up with hypotheses. Yeah. But I would be tempted to say that all the experiments you've done, you manipulate one stream, exteroceptive or interoceptive, and you show consequences of the other one. But it would be very interesting to see whether, if you were to ask individuals to rely on both interoceptive and exteroceptive cues to solve a problem, having done this training, would they be more able to rely on one than the other, or would that simply disengage? And I would be willing to bet, because it costs me nothing, that autistic individuals or individuals with autism in whom you would have increased interoceptive accuracy may well be less reliant on their interoceptive signal than you would predict, even though it would be more accurate, because it would be more overwhelming. So they would develop an adjunctive response. They would develop an escape response away from it. And if you make the interoceptive signal too overwhelming, they may well come back to it as a default mode. So I would be very, very inclined to determine whether there is a disengagement from perception of any stream, depending on how accurate it is.
And I've just published a review article in Autistic Individuals looking at interoceptive and exteroceptive processing across all different senses. And what struck me in that review was there was essentially nothing on the interplay between interoceptive and exteroceptive. Everything's done in isolation.
Yeah.
And actually we need to understand the dynamic relationship. And I think it's such an exciting area for the future, the dynamic relationship between processing the wild and processing self, and what that means. And in psychopathology and anxiety and depression, there's such a dominance of self-referential self-processing. And actually it's key to stop the stickiness of self in some way to help people engage in the world. And stickiness of self can be like augmented processing of the heartbeat potential in brain. Like you can get these neural markers of self. And I do see, in addition to just the nature of sensory processing, in alignment with your questions, I think it's core to the processing in general is to look at this dynamic interplay between internal, external, and how that's altered in different clinical conditions. Yeah, but I like your sensory processing thing to also hook it on.
May I have another one? I was very interested in your extinction study, if I may say so, from a learning theory point of view. As you well know, extinction is context dependent. Craig and others have suggested that the interoceptive landscape takes precedent over any exteroceptive cue in determining the context. So if that view were to be true, one could predict that manipulations of extinction of interoceptive cues should not be context dependent because they tap onto a key element of the context, which is the interoceptive landscape.
Okay, right.
Is that what you have?
Okay, all right. So I got a really bonkers experiment, which I didn't present here because it's so complicated, and it's maybe something like it was in the Journal of Experimental Psychology General, which is using an internal context with the heart. So it's where we show that if you have a CS plus and a CS minus, and you put them on systole, and a CS plus and a CS minus, and you put them on diastole, initially, initially people can't learn the difference between CS plus and CS minus. Everything on systole evokes a fear response. Okay, so that bodily signal overshadows the differential learning of CS plus and CS minus. We then have a between subjects manipulation where during extinction, they're either extinguished using the same cardiac contingencies, or the different one where systole is now on diastole and diastole is now on systole. And we see what then happens during extinction. And it seems like doing that messes everything up. So people don't, it seems like you don't get good CS plus, CS minus differentiation when you've switched the cardiac contingencies.
So if I'm not mistaken, you've not only have you done extinction, but you've also, to some extent, devalued the discriminative properties of the interoceptive occasion setter.
Yeah, exactly.
Which is quite similar to the feature negative discrimination tasks, whereby satiety or hunger can influence substantially how conditioned stimuli paired with food would influence behavior, which is hippocampus dependent. I was more thinking about training individuals in your task, in changing completely the interoceptive state. So here you've trained them to change the interoceptive response to particular cues. And that should generalize outside the laboratory setting. So my question is, if you were to go and record these patients in their home, would you show the same behavioral effects that would then demonstrate that the behavioral effects is not tied to the laboratory setting, as you would have for extinction of cues in the context of addiction, for instance?
It's maybe I'm getting tired, and so I can't be able, but I think, no, because they're really interesting concepts and they're complicated for my brain. I don't know if I'm simplifying what you say, so forgive me if I am, but are you saying, and if you are, I agree with you, that internal context operates the same as external context?
Well, yes.
And so when you're interested in the nature of conditioned learning, yes, well established that external context affects and the specificity of context. And what's disregarded is how the processing of cues is also a function of internal state, because that influences the nature of neurorepresentation. And systematic change of internal state through drugs, through emotion, through anything, will also shape the nature of conditioned learning, extinction, retrieval, and all of the different parameters.
Yeah, so that I'm so sorry. I think you've been very kind. Instead of saying I was unclear, you said I was too complicated. So the point here is, one could go as far as to say there is no such thing as a purely exteroceptive cue. Each exteroceptive cue is being read onto a particular interoceptive landscape.
That's exactly what I think, and that's what my my paper shows. It's 2021. It's really recent. It's just come out. But yeah, I think that's what I think there's so much to do there in terms of bodily manipulations to shape conditioned learning. Yeah.
Gabby, can I jump in and just ask one other question related to this, but just in picking up on this diastole-systole differences? Have you looked at it in relation to trait anxiety? Are there differences in that sensitivity depending on anxiety levels?
Yeah, there is. So it's just a preprint at the moment, but what we find is that I do want to show you it because it's actually we do. We find that you get this boosting, the cardiac boosting of fear is further boosted in people prone to anxiety.
Oh, it's actually enhanced.
It's actually enhanced,
right.
So it's
Right.
actually enhanced. So the way that I account for it is that there's something about this heart-brain channel or the manifestation of cardiovascular arousal in the brain, which increases the processing of fear. And that's where I bring it back to PTSD. So I haven't shown it yet, but ultimately my dream is to do PTSD again and show there's something about this signal that boosts anxiety. Brain-body integration in terms of cardiovascular responses is greater at boosting fear in people prone to anxiety.
Because the only reason I'm thinking is because the other thing that you find is that having high trait anxiety, you're actually much poorer at CS plus, CS minus discrimination. So it actually impairs your discriminability.
But aren't they separate? But they're separate. They're separate things. One is one generalization of fear, and the other one is a augmentation of fear due to cardiovascular state.
Yeah, but I was just thinking the fact when you were saying you could get a really good, if I understood you correctly, you got really good CS plus, CS minus discrimination if they both came in on the systole.
Oh no, you get no discrimination. You get no discrimination. So
sorry.
it aligns with you. I'm so sorry.
Right.
No. It's
Brilliant.
completely what you say. No,
Okay.
gosh, no.
Perfect.
No. You get no. It's actually perfect.
Right.
So people with high anxiety cannot, in fact, the effect is completely driven by people in high anxiety. People with high anxiety have no difference between CS minus and CS plus at cardiac systole.
Right. Okay.
Yeah, thank you so much. Sorry, is exactly aligned with what you're saying.
Well, Sarah, I'd love to stay 2 more hours, and I believe many of those who have stayed with us so far would do the same. But we've squeezed you so hard. I feel guilty now.
No, it was such a pleasure. I had so much fun. Thank you.
It was great. Thank you so much for this nice discussion, and I can't wait to continue it. I hope in person very soon.
Yeah,
thank you all for the very nice discussion. Thank you, Sarah. Thank you.
For staying. I really appreciate it. That was a long time.
Thank you very much.
Bye-bye.
Bye-bye.